Hello, everybody. My name is Marco Valgimigli. I'm an interventional cardiologist working as a deputy chief at the Cardiocentro Ticino Institute in Lugano, Switzerland. And I've been asked, in a way, I was given the privilege to write a chapter on the radial access. And the first question I would like to address is why a chapter dedicated to the radial access. And I think the answer is because radial access has become a default approach, the recommended default approach by both European and American guidelines, with a class 1A recommendation to be preferred over femoral access in patients where this access site is feasible and there is enough technical skills in the team. Throughout the last 31 years, radial access has imposed itself as the way to go for multiple reasons. The first one, which is a bit obvious, is the fact that it is a very superficial artery and therefore is associated with lower bleeding complication. And also the fact that the patient can mobilize him or herself much quicker and allows very easy and safe same-day discharge, both after a diagnostic as well as an interventional procedure. However, throughout the years, a lot of studies have focused on the topic, have randomized different settings of patients to either radial access or transradial access, mainly actually patients with myocardial infarction, either with or without ST segment elevation. And the final outcome of all these studies has been summarized in this chapter, which is telling us the information that radial access not only prevents bleeding complications, reduces the risk of vascular complication, but also is associated with lower mortality risk. In this chapter, we had the privilege to review the latest evidence on the topic. And in fact, we are discussing that bleeding is probably just a small component of the reason why radial access is associated to that lower mortality risk. And potentially that could actually come from preventing the risk of acute kidney injury, which has been shown to be lower with radial compared to femoral access. Now, this is a very extensive chapter where we review quickly the historical notes, how we got there, what were the reasons, what are the anatomical features of the access site, what are the complications, how to best prevent them, and lastly, but not less importantly, we have also reviewed the very recent new technical features of getting radial access, not only in the conventional approach, but also distal, the so-called distal radial artery, which is getting more and more popular, perhaps even more technically challenging and potentially associated to even lower risk of radial artery occlusion. So I hope you will enjoy the reading to this chapter. And if you have any comments or questions, I will be very happy to receive those. Thank you very much.